I will start with dissecting cellulitis. Dissecting cellulitis is a quite unusual type of cicatricial alopecia because it starts as a non-cicatricial alopecia. And if we catch the moment, then we are able to have a full hair regrowth in these patients, even though it's cicatricial alopecia, so unlike in other types of cicatricial alopecia. Just shortly about the diagnosis in trichoscopy, we will find in the early phase the big 3D yellow dots. Sometimes there's still a residue of the hair inside, which will mark it with a black dot. The disease is quite common in patients who are bodybuilders. So my first approach to treatment is to ask about anabolic steroids. And if the patients are taking anabolic steroids, then I advise to discontinue, which usually is a problem because it's a way of life. And going on to pharmacotherapy, there is consensus or maybe more a recommendation from a few years ago. And the recommendation says that if it's mild secondary cellulitis, we should use doxycycline. If it's moderate, then the treatment of choice would be either isotretinoin with or without triamcinolone or a short course of other steroids. And in the severe form also, the isotretinoin is a matter of choice. However, the authors recommend a quite big dose of isotretinoin because most of my patients with secondary cellulitis, they're more than 100 kilograms. And with this, it makes 50 milligram of isotretinoin, which is really a high dose and often with several adverse events. What is new in the area are the TNF inhibitors with multiple informations in the literature showing some efficacy, both about adalimumab and about infliximab. And one of the studies which was performed in 26 patients has shown that after 19 months, so almost 2 years, after 2 years, maybe 1 year and a half, after the introduction, the number of nodules has decreased from 7 to 0.5. So not full remission, or in most patients, not full remission, but this seems to be a treatment of future for patients with dissecting cellulitis. My first choice in every case of dissecting cellulitis is isotretinoin. I usually start with 20 to 40 milligram. If 40 milligram is not effective, I would discontinue and change the treatment. Sometimes to the isotretinoin, I would add some steroids, but only in cases where the nodules are very painful or the inflammatory process is really very active. Otherwise, I leave the patient only with isotretinoin. If this is not working, and this is quite rare, because usually it requires quite a long treatment with isotretinoin, in my hands, usually more than 1 year, sometimes more than 2 years, but then it's possible to discontinue. But if I try to discontinue and there's a relapse, then my second choice is adalimumab. Why is it the second choice? The second choice is it's because first, it is more documented that isotretinoin is effective, and second, the reason is the cost of the treatment, because isotretinoin is reimbursed in our country and adalimumab is not reimbursed for dissecting cellulitis. It's only reimbursed for psoriasis. Few words about folliculitis decalvans. Folliculitis decalvans, the so-called doll's hair, as some of our patients say. Here in trichoscopy, you see the tufts of multiple hairs, usually more than 8 or more than 10. Sometimes small tufts we can see also in other diseases, such as lichen planopilaris. But if we see a tuft of so many hairs, we can be sure that this is folliculitis decalvans, regardless of the other features in trichoscopy, which is related to folliculitis decalvans. Regarding the recommendation from the literature, the first recommendation from the literature is we should start with rifampicin, either in monotherapy or in combination with clindamycin. If I use this combination, I start with clindamycin and then sometimes I add rifampicin. There's a limitation on this method of treatment, which I'll mention in a moment. Some alternative therapies, such as doxycycline, in my hands, they don't work, so I do not use doxycycline in folliculitis decalvans. There's another option which is controversial, and this is isotretinoin. Some of the experts say it doesn't work, some say it does work. I find that there are patients who have a beneficial effect after isotretinoin. And sometimes this is the method, this is the therapy which I would choose because the limitation of the antibiotics, especially of clindamycin and rifampicin, is that we should not use it longer than 16 weeks. Within 16 weeks, which is 4 months, nobody will get a full remission in folliculitis decalvans. So because of this, sometimes I try to do 16 weeks and then discontinue, switch to something else, and then go back to the 16 weeks with clindamycin and rifampicin. However, in such cases, it's always a problem what to use in these patients. A kind of novel treatment, and here Bianca is a co-author, is about adalimumab in folliculitis decalvans. My impression is that it's okay, but the effect is definitely not so good as in patients with dissecting cellulitis. I see some improvement, but never like a full remission, and 40 milligram is not working. We should use at least 80 milligram. So what is my preference for folliculitis decalvans? My first choice, and it's not in the literature, but it's soon to be published, it's trimethoprim sulfamethoxazole, usually with a small dose of corticosteroids. And if it's not working, I would switch to isotretinoin, again to a quite low dose. And if it's not working, I would switch to adalimumab. And if I do it, I may start with 40 milligram every 2 weeks, but usually I would use it in a dose of 80 milligram. So now switching to lichen planopilaris. In lichen planopilaris, the additional problem in our patients is the burning, the pain, and the pruritus. So we also need to take care of this on top of getting a remission of the hair loss. In trichoscopy, we will see the typical perifollicular scaling as the hallmark of the disease. Some lonely hair may be present. And there are 2 articles that summarize the efficacy of different the pharmacotherapeutic methods. The problem, again, is these studies are small and really it's difficult to draw definite conclusions. However, these are the results of these 2 studies. Maybe we can say they indicate that the 3 most effective treatments in lichen planopilaris are cyclosporin, methotrexate, and hydroxychloroquine. This is the typical dose used on the basis of literature, and I would like to share with you some of the thoughts about my preferences. Regarding the cyclosporin, I start with a low dose. I always have a preference to a low dose if possible, and I start with 100 milligram per day. Methotrexate, if I use it also 15 milligram every week. However, I always combine it with steroids, either intralesional or oral. Mycophenolate mofetil, I rarely use it or not so often. However, if I use it, I make sure to go up to the dose of 3 grams per day before I discontinue, believing that it's not effective. Prednisone or in general steroids, I do not use in monotherapy in patients with lichen planopilaris. Isotretinoin, I use in low dose, and this will be the same for frontal fibrosing alopecia. The reason I use low dose is that patients with lichen planopilaris, they are usually patients who are over 50, over 60, over 70, and they have very easily adverse events, especially dryness of the mucous membranes. So to avoid this adverse event, it is important to keep the dose quite low to be able to treat for a quite long time. Intralesional steroids, There was a tendency some years ago to decrease the dose and to increase the volume, and I think we are moving again towards less volume and higher concentration. I'm using usually 10 milligram per milliliter. However, also some of my colleagues are using 2.5. And hydroxychloroquine, if I use it at a typical dose. So can we use JAK inhibitors in lichen planopilaris? I would like to share with you two studies which have been shown in this regard. This is a study on tofacitinib, 2.2 times 5 milligram, and it's important to remember that the dose which is higher is is contraindicated because of possible adverse events. 1/3 of the women had no response, and 2/3 had a partial response. And when we say response, we have to remember that it is differently defined by many authors. Some are using the scoring system, some a general impression about improvement or not. However, regrowth is sometimes possible when this is a very early form. In other cases, we will not have a regrowth. There's one study with baricitinib in lichen planopilaris, and here again the data are not so very optimistic. 50% of the patients had no response, and approximately 40 patients had some partial response. And one patient had a complete remission, whatever this means. What is new and maybe worth trying because it lacks adverse events, it's an acetylcysteine. There are 2 or 3 articles now on this topic on acetylcysteine being effective in lichen planopilaris, usually in combination with something, here in the combination with clobetasol topically. I am not sure it's sufficient data, or I'm sure it's not sufficient data to use it in monotherapy, but I think as an additional treatment in patients who already received another treatment, I think it's worth trying. So what is my approach? I would usually start with cyclosporine. Cyclosporine is, in my hands, quite effective. However, we should make sure that the patient does not have mucosal lichen planus, because if they have mucosal lichen planus, they will have very often the hypertrophy of the gingiva, which makes it impossible to continue the treatment. And I would combine this at least at the beginning with intralesional triamcinolone. I start with intralesional triamcinolone every 2 weeks, then I go every 4 weeks, then I go every 8 weeks, and so slowly I discontinue. If this is not effective or if it's contraindicated, then I would go for methotrexate at the usual dose of approximately 50 milligram, and then for other treatments. And we have few patients on JAK inhibitors with moderate efficacy. If frontal fibrosing alopecia coexist, then I would probably try isotretinoin. I go on for approximately 4 to 6 months, and if the patient still has itch or pain or burning, I would then change the treatment. If the hairless area is increasing, I would change the treatment. However, if there are trichoscopy signs of the disease activity, we have observed that usually trichoscopy signs of disease activity are not associated with the increased in the size of the hairless patch. So in such cases, I would continue treatment as it was and see what happens in the future. In frontal fibrosing alopecia, and I see I have to speed up, which we all know what is the clinical picture. In trichoscopy, the lack of vellus hairs will be the most characteristic feature. There are 2 filers of treatment. First filer is the anti-androgenic treatment, and the second filer is anti-inflammatory treatment. I usually combine treatments from these 2 filers, and my approach would be that I start with isotretinoin, low dose again. With finasteride, I start with 2.5, I increase to 5, and sometimes I also add intralesional triamcinolone, taking care that I do not develop, or the patient does not develop atrophy. So just to conclude, in conclusion, I will just mention what's new. In dissecting cellulitis and in folliculitis decalvans, adalimumab, and if we try adalimumab, always at the dose of 80 milligram, not less, because less is not effective. In lichen planopilaris, the JAK inhibitors, and possibly N-acetylcysteine. We will see about this treatment in the future. And frontal fibrosing alopecia, also JAK inhibitors. And what is new here, or quite new, not very well documented, is the use of methotrexate, which has been shown effective in several cases. With this, if you plan to travel to Poland, please come in May next year. We will have a big conference about hair diseases. And with this, I would like to thank you very much for your kind invitation to Dubai. Thank you.